Hi, everyone. I am presenting for the group consisting of Jameson, Bailey, Madison, Silver, and myself, David, and we'll start with the screencast. So our group is presenting on continuous quality improvement and outcome strategies in healthcare. The ever-evolving nature of healthcare is largely shaped by an industry-wide shared commitment to bring evidence-based best practice to the treatment of patients. Understanding what this entails is a field in and of itself. In this presentation, we will discuss the purpose and goals of continuous quality improvement, otherwise known as CQI, the strategies employed, what forces drive healthcare entities to set such goals, and what barriers there are when implementing CQI. We will then cover CQI's implication for nursing professions, such as why CQI matters to nursing, what nurses see that triggers the need for CQI, and how specific nursing roles contribute to the implementation and successful outcome of CQI strategies. The purpose of continuous quality improvement is to reduce variability and costs, meet regulatory requirements, and improve customer service outcomes and quality. It requires that all members of the healthcare team identify problems in their facility, implement and monitor the actions put in place to correct those problems, and then study their effectiveness. In a 2020 article, O'Donnell and Gupta stated that other goals can include decreased appointment wait times, higher patient volume, increased patient and staff satisfaction and safety, and reduced patient stay time in the hospital, along with early recognition of diseases and illnesses. The same 2020 article discussed different strategies of CQI. We've listed 4 of the most common strategies, which include the Lean strategy, Six Sigma strategy, Plan, Do, Study, Act, also known as PDSA, and the Baldrige Award criteria. And we'll discuss those a little further. So we'll start with the Lean strategy, which was originally developed by the Toyota Corporation to improve customer satisfaction and reduce waste. But we can probably start to wonder, like, what can a car manufacturer teach us about how to better care for patients? Well, its structure can and has continuously been applied to healthcare. The main focus is to cut out unnecessary steps so that the patient gets what they need in the most timely and effective way. The authors of the Consumer Assessment of Healthcare Providers and Systems Ambulatory Care Improvement Guide state that by taking out steps that add no value to the process of patient satisfaction, the process moves more smoothly and efficiently. The result is reduced cost, shorter wait times, and shorter stays at the hospital. In a 2007 article, Nelson Peterson and Leppa discussed the application of the Lean strategy in the medical setting. The Virginia Mason Medical Center began implementing what they called the Virginia Mason Production System, which was a CQI based on the Lean strategy. And in the hospital, they started a patient safety alert initiative and used the Lean strategy to cut out unnecessary steps when it came to reporting safety problems. The overall result was a more efficient and effective system that in turn gave managers the opportunity to have these reports investigated and resolved in a more timely manner. In the 10 years that followed the implementation of this strategy, the hospital saw liability claims drop by 74%. So next, we'll talk about the Six Sigma strategy. This was developed by the telecommunications company Motorola and is highly used in manufacturing companies, but like the Lean strategy, its application is very effective in the healthcare setting. Its purpose is to eliminate errors, defects, and waste. It's a 5-step process, which can be a little confusing because the title is Six Sigma. The first step is to define the problem and set a goal with a process that details each step. Next, you measure the process and identify any inefficiencies. Then you analyze the information collected and identify the cause of the inefficiencies. This will allow you to improve by developing and testing solutions for the problem and control the procedures that are effective and frequent and do frequent monitoring and documentation. You cycle and repeat. Uh, some outcomes of this strategy when applied to healthcare include shorter wait times, preventing patient falls and injuries, along with reducing medication errors. Here are some examples of what hospitals were able to achieve when using the Six Sigma strategy. In a 2016 study, Simon and Denise found that after implementing the strategy, a private hospital in Turkey was able to double their patient capacity from 32 to 64 without hiring any new staff. The study that I saw didn't give me a time frame, but 32 to 64 without hiring a new staff is pretty significant. Um, and then in another study in 2018, Dr. Aminu described the effects of the strategy as it related to ST segment elevation myocardial infarction patients. Door to balloon time is a phrase that denotes the time between the arrival of a patient with STEMI in the emergency room until the time that a balloon is inflated in the occluded coronary artery. The recommended time frame is 90 minutes for success. Dr. Aminu stated that a nonprofit hospital applied the Six Sigma strategy and saw their rate of successful door to balloon time ratios go from 47% to 73%. So by implementing the 5-step Six Sigma strategy to define, measure, analyze, improve, and control, these healthcare facilities have been able to treat more patients and reduce wait times for critical procedures, which all led to improved patient outcomes. So next is the Plan, Do, Study, Act. This one is the most involved as far as explaining. So to start, you want to ask 3 particular questions. What are we trying to accomplish? How will we know that the change is an improvement? And what changes can we make that will result in an improvement? So the first step is plan. You assemble a team, come up with an aim statement based on the questions listed. Then you examine the current process and describe the problem. And then you assess the causes and develop some new alternatives. Step 2 is the do phase. This is where the staff and company put their plan into action. During this stage, data should be collected to later be evaluated. Document the good, the bad, the unexpected problems, successes, and general observations. Flowcharts and check sheets may be useful in this stage to maintain organization and to document instances as they occur. The next step is the study phase. Here, the team will be evaluating the outcomes of their plan and predictions. They will assess the degree of improvement and ask questions such as, was the plan of action worth the investment? Does the data line up to the predicted outcome? And what are the unexpected side effects? During the final phase, which is known as ACT, the team will reflect on the outcomes and decide whether their plan was successful or if a different approach is needed. If the plan was determined to be a success, then it should be standardized and put into effect regularly. And then after a given amount of time, that plan should be reassessed for further improvement. If the plan was found to be not a success, then the team should start back at step 1, at the plan phase. The PDSA method is a cyclical rather than linear approach. Therefore, it's an ongoing process that results in effective communication, team building, and patient satisfaction. So the Minnesota Department of Health provided an example of PDSA at Blue Ox Medical Center in Minneapolis. The aim was that in January of 2007, the hospital set out to increase the number of follow-up primary care visits scheduled for stroke patients prior to discharge from 50% to 70% by June of 2017. So a 20% increase in 6 months. They set their plan, which was that follow-up appointments would be made and noted in charts by a health unit clerk for inpatient neurology unit patients. In order to allow this to be done, many tasks were set in place. These included scheduling follow-up appointments, that was built into the order set and establishing procedures and scheduling appointments on weekends and after hours. So on the do phase, it stated that what actually happened was that during the week, the health unit clerk scheduled the follow-up appointments. And for discharges that occurred on weekends, the appointments weren't scheduled. So the study phase indicated that case review, chart audits, and interviews found that discharging during the week um, produced an increase in the number of appointments scheduled. So that was a success. But for weekend patient discharges, the health unit clerks did not set as many follow-ups. So that needed to be improved. And in the ACT phase, it indicated that stroke coordinator reviewed the process for patients discharged on weekends. And if the patient's primary care provider is in the same health system, the emergency department nurse that conducted the 72-hour post-discharge follow-up phone call would make the appointment on Monday morning. So next we'll talk about the Baldrige Award. In 2005, Poulter helped describe the Baldrige Award criteria. She stated that it focused on improvement for enterprises rather than for a single business, office, or hospital. So there are 7 categories for the healthcare criteria. They include leadership, strategic planning, focus on patients and other customers and markets, measurements, analysis, and knowledge management, staff focus, process management, and finally, organizational performance results. There needs to be a lead in each one of these categories to manage improvement. Its aim is to increase patient satisfaction, emphasize leadership, and yield organizational performance results. Award recipients are chosen and recognized as being role models of performance excellence. 3 such winners included the Baptist Hospital Incorporated in Florida, St. Luke's Hospital in Missouri, and the SSM Healthcare, which is a nonprofit Catholic healthcare system. Each institution submitted a 50-page description of their organization that met all 7 criteria for award eligibility. And after that, they underwent several phases of reviews before being selected as winners. An example of a criteria question was, what are the current levels and trends in key measures or indicators of healthcare outcomes, healthcare services, and patient safety? So some external drivers for CQI. In 2006, Brindis and Demmer discussed that pay for performance, or P4P, initiatives were thought to motivate hospitals to implement CQI with the incentive of getting payment for taking the time and effort to install new interventions and programs. Healthcare stakeholders, like certain organizations, American Heart Association, push hospitals to participate in CQI programs, and they present these interventions and help get the hospital on board with implementing the program. Along with improving patient outcomes, enhancing services, and reducing costs, these 2 drivers are also the main reasons for CQI programs to be implemented in our healthcare systems. Next, we wanted to talk about some barriers to CQI. In 2015, Candice, Jobin, Dubé, Tozignant, Abdel Jalil, Grenier, and Gagnon performed a mixed method systemic review of the literature to find barriers and facilitators to implementing continuous quality improvement programs in colonoscopy services. And although the study focused mainly on the people or the doctors performing the colonoscopy, it also took into account the perspective of nurses, managers, and patients. So these researchers looked at 15 studies and extracted 99 findings from them to analyze facilitators and barriers to implementing CQI. The study found that the most common barrier to implementing CQI strategies was concerns over feasibility and adaptability, but other barriers included training and education, clarity of the intervention, attitudes and perceptions, or negative attitudes and perceptions, cost and cost effectiveness, and maintaining compliance. The researchers touched on how to combat some of these barriers. For example, they found that having a sense of ownership with the program helped create a more positive attitude, therefore helping negate that negative attitude and perceptions. Other solutions to some of the barriers included involving all users in the planning and implementation and providing access to training, materials, and human resources. In a 2010 interview, Cynthia Barnard, a registered nurse, stated that the role of professional nurses in quality improvement is twofold: to carry out the interdisciplinary processes to meet organizational QI goals and to measure, improve, and control nursing sensitive indicators, otherwise known as NSIs, affecting patient outcomes specific to nursing practices. So, what does CQI mean for those in the nursing profession? In other words, what are the implications to nursing practice? Well, first and foremost, nurses hold an ethical responsibility to promote health and safety. Prior to quality improvement, nurses were usually the ones reporting improper practices. QI leads to increased patient safety and allows nurses to provide care that they are proud of. QI strategies help healthcare entities to establish clear rules by which to practice skills, as well as clear steps to do procedures that ensure they are done as appropriately and safely as possible. When the cause is an inefficient healthcare system, the goals become to increase productivity, reduce costs, and make institutions more competitive. Using a strategic CQI model will help identify defects and wastes in the hospital service line, produce better outcomes such as improving rates of morbidity, medication errors, readmission, length of stay, and mortality, and provide clear standards and regulations so that staff can rely less on judgment and more on rules and policies. If quality improvement is sought due to a lack of systemic evaluation, the aim is for the hospital in question to perform well and stay competitive while providing quality care. To evaluate the quality of nursing care, there are nursing sensitive indicators such as nurse staffing, pressure ulcer care and numbers, patient falls, and hospital infections. Insufficient staffing is also a trigger for the pursuit of CQI. Higher patient to nurse ratios result in burnout and job dissatisfaction among nurses, which translates into decreased quality of care for the patient. The American Nursing Association works to educate hospitals about decreasing nurse to patient ratios um, or patient to nurse ratios and provide floors with enough nurses for safe care. The role of the bedside nurse is fundamental. Bedside nurses are the key to quality care. They are in the best position to advocate for the patient. The healthcare facility and the patients rely on them to correctly follow policies and procedures, and bedside nurses are the most active points of contact in patient care, which in turn means that they are often well positioned to witness and report on improper actions. So now we can look at the role of the nurse manager, and as can be expected, nurse managers do a lot of the heavy lifting behind the scenes. Included among them are careful shift planning, checking in on the floor nurses to assess their needs, figuring out ways to get new and important information to floor nurses on their unit, for example, by email or through nursing information systems such as Epic at UC Health. Setting up a system that allows for self-scheduling and coordinating quality improvement processes to bring measurable improvement at the unit level. So the nursing officer is in charge of the nursing department's participation in continuous quality improvement. They integrate nursing practices into the goals and they communicate to all levels of the nursing staff. So some sources for evidence-based practice, they include policy books, um, facilities websites, asking a manager or a charge nurse for information, upgrading systems to have frequent tabs that are easy to access, using fast system speeds, aiming for simple and efficient processes, and by attending educational meetings where nurses can see firsthand where evidence-based practice were sourced. And that is the end of our presentation. We have a list of references. You can feel free to click through them, and there are quite a few. So thank you for participating, and take care.